Hi, everyone. We're just going to give a moment for everyone to come in. You'll see here up on the screen, and I'll announce again, we have put together a survey to solicit your feedback on the global dermatology talks. And so any availability to fill this out for us would be greatly appreciated. It should be pretty easy. You can just scan the QR code that's up on the screen, and it should take you right to the survey. Which should not take very long to complete. I'll show this again at the end. All right, we'll probably give it about another 30 seconds or so. For those just coming in, we have a survey that we'd love to get your feedback on global dermatology talks as a whole. So please feel free to do that for us. We greatly appreciate it. We'll send along an email and also show this QR code at the end of the talk today. All right, well, it's 12:02, so I think we'll get started. Today's speaker is Dr. Paul Nghiem. Dr. Nghiem is the George F. Odland Endowed Chair and Professor at the University of Washington in Seattle, Washington. Dr. Nghiem is also the head of dermatology there. Dr. Nghiem completed his undergraduate studies at Harvard. He then went to Stanford, where he completed his MD and PhD studies. There he studied cancer, biology, and immunotherapy. He then went back to Boston for his dermatology residency, which he completed at Harvard. Also at that time, he performed a postdoc with Stuart Schreiber and studied the roles of DNA damage repair in response to ultraviolet radiation. He started his lab there in Boston in 2003, but after a few years, returned home to Washington, where he remains today. Dr. Nghiem is a world-renowned leader in Merkel cell carcinoma. Among other things, his group has performed work leading to the first 2 FDA-approved therapies for advanced Merkel cell carcinoma. His group has developed a blood test to detect Merkel cell carcinoma recurrence, and equally important, he's developed many important resources to help Merkel cell carcinoma patients and those caring for them around the world. We're very fortunate to have Dr. Nghiem with us today for our final global dermatology talks of this year. Please join me in welcoming him. Dr. Nghiem actually will give his presentation remotely. We have a pre-recorded video here, which I'll share, and then we're fortunate enough to have him join us towards the end of the session to answer any questions that you might have. So without further ado, I'm going to share my screen here and play Dr. Nghem's talk.
Hi, my name is Paul Nghiem, and I'm pleased to talk to you today about Merkel cell carcinoma towards more effective and less toxic management as part of the Global Dermatology Talks, which I hope we're all sharing information around the world effectively, even if we can't travel so readily. Thank you. So here are some relevant disclosures relating to companies that I've interacted with. And I'm going to address today the goal from the patient's perspective. The most important thing is you want highly effective treatment that is not unnecessarily toxic. And I think both of those things are very important to consider in this aggressive skin cancer. So I'll give you a few high-level overviews of Merkel cell carcinoma these days, and then talk about 3 stories that start with an S: surgery, surveillance, and systemic therapy. So surgery, we are moving from a knee-jerk reaction of every Merkel must be excised widely to one where we aim for wise margins, often, not always, incorporating radiation therapy in the initial local management and or regional management. Surveillance is a big, tricky area in a cancer that's going to recur in 40% of cases. And we, in the past, had just guidelines that said, do surveillance as clinically indicated. And we need more data. And those are emerging now, as well as two very useful blood tests for detecting this cancer recurring when it's very early. And then systemic therapy, we've now moved in the front line, in most cases, strongly away from chemotherapy and towards immunotherapy. And I'll summarize those data. And then the ongoing challenge, the biggest challenge the field faces, is what do you do about disease that is advanced and refractory to PD-1 or PD-L1? Where are we going with regard to this? And the good news is I think there's lots of reasons for optimism, but there's a lot of work to be done. So why is Merkel cell carcinoma important? Here's a few introductory concepts, then a few images here of relatively advanced Merkel cell carcinomas. Presumably anybody who sees these is going to say, we need to do a biopsy of that thing. But this is a more aggressive cancer than melanoma, with 30 to 40% mortality as compared to about 8% for melanoma. Everybody knows that it's an aggressive cancer, and therefore there is high morbidity with therapies that are often applied in an aggressive way. Wide margin surgery, extensive radiation, frequent CT scans, and infusions of a variety of agents that can have toxicities. So those things all need to be balanced, and there is increasing incidence of this cancer. It is going up quite rapidly, although it is a rare cancer to start with. And if you look at all cancers, all solid tumors in the United States between the year 2000 and the year 2013, there was approximately a 15% increase in all cancers. So there's our baseline. Melanoma, as you all know, in dermatology is going up significantly faster than that, with a 50% increase roughly over those 13 years. And Merkel has essentially doubled during that period, going up significantly faster. So why is this observed increase and then the projected increase? Now we're at 2020 and we have verified that there are over 3,000 annual cases of Merkel cell carcinoma in the US. Why is this going up so quickly? In a word, it is age. And here is the relationship between age of all cancers, all solid tumors, as we get up into our 40s, 50s, 60s, 70s and such, the percentage of cases go up and then actually falls off, in part because the population is less, but probably the cancer risk is actually going down a bit too. Merkel is a bizarre cancer in that there's a unusually long delay, as we'll talk about in a few minutes. There's a virus that causes most of these cases. We are exposed to that virus as children. We get it when we're children. And why is there a 6-decade delay between getting the cancer and or getting the virus and developing the cancer? I think the simple explanation for this incredible cooperativity between age and the incidence of this cancer is immune senescence. That is the simplest explanation. It's almost certainly playing a significant role. You also need multiple mutations, which is true for all cancers. But why it would continue to go up like this is probably associated with immune senescence. And we'll come back to those concepts in a few minutes. So making the diagnosis of Merkel cell carcinoma is hard. The clinician's impression at the time of biopsy in 106 Merkel patients tells us that, these are earlier and more banal appearing little red bumps, and you often actually don't even have redness, but in most cases it'll be red or purple. And on the day the clinician did the biopsy in over 100 cases, they thought in most cases this was something benign, like a cyst or a lipoma or a dermatofibroma. And about a third of cases they thought something malignant, some kind of non-melanoma skin cancer, and only one person suspected Merkel cell carcinoma. So that is a tricky diagnosis to make upfront. This is kind of useful and interesting in retrospect, at least, this AEIOU, characteristics of Merkel cell carcinoma. If you have a tumor that is a lump that is asymptomatic, that is expanding rapidly, especially in an immune compromised person over the age of 50 and occurring on UV exposed fair skin, then those characteristics are associated with Merkel cell carcinoma, and about 89% of Merkels that will have 3 or more of those. So this is a sensitive metric. It is not specific. Most things that have 3 or more of these features will not actually be a Merkel cell carcinoma, but actually probably maybe something that needs a biopsy. So if you have a red, rapidly growing, non-tender nodule on sun-exposed skin of somebody over 60, especially if they're immune suppressed, you probably ought to do a biopsy there. Okay, so that's the high-level overview, and now we'll jump into surgery and initial management. So before you start with definitive management, what's the first step? Do you need really a full scan at the baseline? Well, in the past, the answer has been no for Merkel cell carcinoma because the guidelines were simply based on those of melanoma. And in melanoma, less than 1% of new invasive melanomas without clinical evidence of disease elsewhere will actually have already had occult spread at the baseline. So the strong recommendations for melanoma are you do not do a scan at baseline if you don't have a strong reason to do that. Merkel, however, we have found, and others, this is multiple studies, but this is the largest one published this year, 16% were upstaged by a baseline PET CT. That is a really large number. That is 1 in 6 patients whose care was radically altered. And this is important because if we miss node positive, or even more importantly, distant positive disease, then we're both giving overly aggressive local therapy that has unnecessary toxicities, and we're delaying systemic therapy, which is what the patient really needs. So this has got important clinical prognostic and therapeutic implications, and the NCCN guidelines and others have switched relatively recently based on this relatively new data and larger data to say in most cases, if it's a patient that you actually want to prospectively manage and you would treat with systemic therapy if they were sick, getting a baseline PET CT is important. Of note, the PET CT is markedly more sensitive than CT at baseline. So NCCN guidelines indicate that PET CT is appropriate and justified at baseline. For surveillance CT, plain CT, diagnostic CT is usually very appropriate and covered by insurance. Okay, so now we're going to talk about a case. And this is a case that teaches us about local management. We have a very typical 70-ish-year-old man with an average sized Merkel cell carcinoma that arose on sun-exposed skin of the left wrist. Textbook management was carried out, not actually by our team, but a standard 2-centimeter margin, that's great, was taken. That left a 6 by 6 centimeter defect, and a skin graft was very competently placed, healing well, and the patient had a negative sentinel lymph node biopsy. So textbook management in many cases. However, there was a 5-month delay in radiation because this large graft needed time to heal. And because the tumor was very close to the deep margin, and you could have known this, you feel the skin on your wrist, and you can't go very deep there. So this was less than 1 millimeter from the deep margin and was higher risk therefore, so needed some radiation in a reasonable assessment of management. And then 7 months later, the poor guy gets a recurrence in his left axilla anyway. So this is the worst of all worlds. He had big surgery, he had a delay, he had radiation, and then he had a recurrence. And we now know that this 5-month delay in radiation markedly increases the chance of local regional recurrence. If you're going to give radiation, you really need to do it within ideally 2 months of initial surgical management, ideally maybe even 1 month. So what do we do? What is the right margin for excising a Merkel cell carcinoma? So the trick is, that's a trick question. You don't want to ask what the right margin is. You need to consider the full context a little more carefully. What do I mean by that? Well, if you're going to give radiation, you don't need huge margins. And the problem in the literature until very recently has been studies have lumped patients together whether they've gotten radiation to the local site or not. And radiation to the local site massively changes what margins you needed. So if you're not going to give radiation, the data are 100% clear from many studies in the literature. You got to have wide margins. And that means greater than a centimeter of margin. If you're less than a centimeter, and all sort of 7 of these cases were pathologically negative at the margin and yet recurred. So you really need larger margins if you're not going to give radiation. Now, if you're going to give radiation, and here's 70 patients in each group here, narrow margins, wide margins makes no difference. Very importantly, many of these even narrower margins or narrower excisions ended up having pathologically positive margins, and they were fabulously well controlled by giving local radiation. In contrast, again, all 7 of these recurrences had pathologically negative margins, clearly demonstrating that Merkel cell carcinoma, which anybody who follows this cancer closely knows can jump 1, 2, 3 centimeters beyond a pathologically negative margin through local lymphovascular invasion. So this is not a cancer that grows like a contiguous ball, and it's therefore tricky to use and have confidence in a Mohs excision, because no matter how good your technique is, the cancer may have jumped beyond your margin. So does everybody need radiation? Absolutely not. Low-risk tumors do not need radiation, and these are 6 characteristics. If you have all low-risk features, we absolutely do not radiate in any way those patients. So a smallish tumor, the margins were negative pathologically, there was no lymphovascular invasion, there was no profound immune suppression such as HIV or CLL or solid organ transplant recipient status. Their sentinel lymph node biopsy was negative, and it was not on the head and neck. The head and neck by itself is a higher risk site for recurrence. If all those features are negative, we never radiate. Nationwide, in the United States, about half of all Merkel patients receive local adjuvant radiation, so it's pretty commonly given. And in our cohort, when we looked a couple years ago, we were surprised that actually 92% of our 800 patients received some amount of radiation. I will hasten to add that we have added a Goldilocks concept. Usually, adjuvant radiation has been thought of as 0 or 6 weeks and nothing in between. I gotta say, that's crazy. There are many cases that are low-ish risk. There is no need for 6 weeks of radiation. It's toxic, it's expensive, it's inconvenient. We are often giving 1 fraction of 8 gray, that's a higher dose radiation, and that's being studied. We're tracking all the data, but we've been doing it for years. It's low toxicity, and it's a significant insurance policy on top of nothing in low-ish risk cases, like maybe where 1 or of these factors is positive. So we're studying it, and there'll be more publications on it. But patients really like it, and we really like it. Low toxicity and convenience. Okay, so coming back to, does everybody get a wide excision? No, this is the point here. You need to do wise excisions, and it depends very much on the context of the patient in many regards. It needs to be customized in a multidisciplinary way. Radiation, and if you were paying attention to those 6 risk factors, on the day the surgeon is doing the wide excision and possibly the sentinel lymph node biopsy, which is usually indicated, you're missing 2 pieces of information about whether you'd need to do radiation or not. And you don't have the sentinel node biopsy, of course, because you haven't done it yet. And the margin status in terms of pathology is not clear yet, because again, the excision hasn't been done. So the simple answer to this is just close primarily. And if you close primarily and avoid complicated flaps and grafts, then you can proceed rapidly to radiation if that's indicated, or if you need to re-excise and want to totally avoid radiation, you could do that afterwards. But this moves the patient quickly to radiation if it's needed and lowers the morbidity. So this is what we recommend at the simple level for managing Merkel tumors. So in summary, the most important aspect is, yes, you do need a baseline imaging study, ideally a PET CT scan, to make sure you're treating the patient fundamentally the right way. 1 in 6 will be radically changed in management. This really requires multidisciplinary discussion. You need to think about the patient, you need to think of the surgical issues, the radiation oncology issues, and potentially medical oncology issues. The best initial re-excision margin is wide, but primarily closed. And radiation provides superb local control, even if the margins are microscopically positive and you don't have to do 6 weeks of radiation to clean up that area in a wider way and improve the outcomes. So next topic, surveillance. Okay, so this is a cancer that will recur in 40% of cases, and surveillance greatly matters, therefore. Because if it's too frequent, you have the toxicity of the scans, and you have unnecessary doctor visits, as well as the financial burden of all of those visits and tests. If it's too infrequent, you miss the early diagnosis, and you lose the time window to fight the cancer. A sophisticated point here is that small tumors don't always respond fantastically to immune therapy, but by catching it when it's smaller, you give yourself more time if plan A doesn't work. You still have time for plan B and plan C, et cetera. If you wait and find it only when it's symptomatic, then there's not a lot of time if your first therapy doesn't work. So in terms of surveillance, we've had survival data from national cohorts for some time, but recurrence data is what's really useful for guiding surveillance, because a recurrence may happen years before death, and you really want to know who's at risk for recurring still. So we now have these data that are available on our website, and paper is finally under submission and under revision at a journal. And this is recurrence data not available in any national cohort by stage using the current staging system. And this is important because if Mr. Jones comes in at 5 years after having a stage 1 Merkel, you can look at data like this and say, Mr. Jones, I think you can graduate from our surveillance program. Your risk is really low. Importantly, Merkel really tends to come back much faster than melanoma, which is bad in some regards, but it's good for the patients who don't have a recurrence after 3 or 4 or 5 years, because their follow-up can become much less aggressive. So if you have, though, Mrs. Smith here, who's 1 year after a pathologic stage 3B disease diagnosis, you can see she's got a lot of risk in the next couple of years. So, and you can actually then start to quote what the residual risk is. So this is very useful and very practical. But stage alone misses several important characteristics of risk of recurrence. And I'll show you here the hazard ratio relating to several patient and tumor characteristics that affect risk. And this is going from a logarithmic scale of 0.1 to 1 to 10. So 1 is the reference, and that's pathologic stage 1 Merkel cell carcinoma. You can see as stage increases through the clinical and pathologic stages, we have a major effect on the risk the cancer will come back. Importantly, unknown primary status is a fascinating aspect of several cancers, but it's really pronounced in Merkel, where if you've got, let's just say you've got nodal disease no matter what, or distant disease no matter what, and you look in a population of such patients, if you and the patient cannot find a primary lesion, there's a 60% lower chance the cancer will come back. We know that this is caused because the immune system got rid of the primary, and the immune system is then more able to get rid of microscopic distant disease and is significantly protective. And patients always come in, this is a happy discussion, because patients are always terrified, saying, oh my God, we could not find the primary, my doctors can't find the primary. And you say, yeah, there isn't a primary anymore. Your immune system got rid of it, and that's good news. So sex, same thing, women markedly protected, 60% lower risk of recurrence. That's obviously not incorporated in the staging systems. Immune suppression doubles your risk, a little bit more than doubles risk of recurrence, very important factor, not in staging system. And then for each decade of increased age over 55, there's a 10% increase in risk of recurrence. So that's not a profound factor, but it's real. So we've now made a risk calculator, and I'll tell you why this is useful. And you can just go to this page or just merkelcell.org/recur, R-E-C-U-R, and you'll get to that beta version of the risk calculator that takes into account all these factors. And why is that useful? Well, if you look at 100 patients who have stage 3A disease, on average, they'll have a 40% chance that the cancer will come back. However, if you look at a low-risk patient, let's call her Mary, she's 50 years old, she's got a good immune system. She's immune competent, and she has an unknown primary. She only has a 22% chance of ever having the cancer come back. And John, on the other hand, a 90-year-old man who's immune suppressed with a known primary on the head and neck, has an 83% chance. So there's a fourfold range there in risk of recurrence that a more precise calculator can capture, where stage alone cannot do that. So that's something we use with every patient as they come back, and it plots out exactly where they are and how many years and how many residual percent risk they have. It's greatly helpful in reassuring the patient and helping us decide how often scans and blood tests should happen. So science is also helping with surveillance. And here, as you all know, in 2008, a human virus that causes Merkel cell carcinoma was discovered. This is a picture of Patrick Moore and his wife, Yuan Chang, a dynamic duo scientist couple that found the Kaposi sarcoma herpes virus in the 1990s, and then 10 years later found the Merkel cell polyomavirus, a totally new virus that was clonally integrated into 8 of 10 initial Merkel cell carcinomas that they found. This finding has been validated in dozens of studies across thousands of tumors around the world. And this virus is fascinating because it's incredibly common. You swab your skin with a cotton swab today, chances are good we could find with PCR the Merkel cell polyomavirus on your normal skin. Children are exposed to this. This causes no direct problems that we're aware of at all, except in 1 in 3,000 people over their lifetime, they will get Merkel cell carcinoma from this virus. So how does such a common virus cause such a rare cancer? We have a very good sense of this now. Again, there's 20% of Merkels in the United States caused by sunlight alone. In Australia, this is more like 40 or 50%. And in Asia, the percent of Merkel's caused by virus is even higher, more like 90%. But we have 2 processes on the viral etiology side here that we now know are both necessary, not yet sufficient, but both necessary, both have to happen at the same time, and are not desired by the cell or by the virus. So these are fluke events, rare events. One is that the virus has to be truncated in a particular region such that portions of the virus are expressed and other portions must be deleted. Otherwise, the cell will die very promptly. And then the virus has to integrate into a human chromosome, which it normally never does. It normally hangs out episomally outside of the chromosomes, in the nucleus, but outside the chromosomes. And so both of these things are rare and have to happen essentially at the same time. And then you get a Merkel cell carcinoma tumor after production of various viral proteins that are generally immunostimulatory and must be evaded somehow. The immune system must be evaded. And then you get a tumor that looks exactly like the tumor caused by sunlight under the microscope and such. And the several aspects of the pathways are very similar, but it takes a lot of mutations to generate this cancer by sunlight, as I'll show you in a moment. The takeaway from this, though, is that both of these causes of this cancer are visible to T cells, the viral oncoproteins and the UV-induced neoantigens. So here is TCGA, that is the Cancer Genome Atlas, mutational spectrum data comparing virus positive versus virus negative Merkel cell carcinoma. So if you look at virus positive, it is actually the least mutated tumor of all in this Cancer Genome Atlas. And you can see it's less than thyroid carcinoma or pheochromocytoma. And in contrast, the virus negatives caused by sun are more heavily mutated than SKCM, which is skin cancer melanoma, and LUSC, which is lung squamous cell carcinoma, which is smoking induced. Both lots of neoantigens in those, immune responsive. And we got Merkel's that are caused by sun at a markedly higher number of, on this log scale of mutations per megabase or tumor mutational burden. So we have clear evidence of immunogenicity in theory in both of those directions. So these are visible both to T cells and for the virus positive component to the immune system, which makes antibodies against a particular part of the virus. And this has become a very useful test. So this was first described by Denise Galloway and in a collaboration with my lab led by Kelly Paulson, antibodies to Merkel cell polyomavirus T antigen oncoproteins reflect tumor burden in Merkel cell carcinoma patients in 2010. After more than a decade of careful study, this has become a clinically annotated, a validated test that is indicated in the NCCN guidelines now for several years. And what we believe is that it's useful to get this blood test done once at baseline because it'll split the population of Merkel patients into half. Those are their seronegative, where there's a 42% chance higher risk the cancer will come back. So you need to track this, those folks carefully. And you can't track them then after this with the Merkel virus antibody test. I will tell you in a moment about circulating tumor DNA, which is a very powerful test, it looks like, for Merkel cell carcinoma as well as other cancers. But for those who are seropositive, you can have fewer scans and follow mostly with serology after you get your baseline and track the patient a little bit. So how does that work? For the half of patients that are seropositive, this is a very powerful test validated in over 1,000 studies, 1,000 blood tests in several hundred patients. So if you had a baseline positive antibody test, then usually we'd recommend every 3 months or so a blood test be done, because if that antibody titer keeps decreasing over time, there's a 97% negative predictive value that there is no current disease that you could detect on scan or on an exam. In contrast, if the titer goes up, then there's a high chance that the patient has already had a recurrence or will soon. And in many of these cases, when we followed them longer, if we hadn't initially found the cancer, eventually it did come back. So it's a very useful blood test. In contrast, for the folks especially who don't make the antibodies, there's an emerging test. There are several probably in the platforms of them, but Bespoke, which is a customized, in other words, circulating tumor DNA test. And this has been well studied in other more common cancers, such as colon and breast, where it's indicated in a number of guidelines and covered by insurance to monitor recurrence, and it correlates with prognosis, and it's very useful in tracking efficacy with immunotherapy. So there's lots happening in this space. But the high-level concept here is if you have a Merkel cell carcinoma on a patient, it will release any tumor, any cell, especially rapidly turning over cells, will release DNA from that tumor into the bloodstream. That only lasts minutes in the bloodstream, so it's very quickly turned over. But if you then assess the tumor-specific mutations by sequencing the archival tumor and then comparing to blood, and you find the handful or maybe 100 unique mutations in the tumor, you can use that in a customized PCR assay. This is all done commercially, in other words, to test whether there's DNA from the tumor in the blood. And here is some preliminary data from 10 patients looking at their baseline circulating tumor DNA as a function of the size of their tumor between 1 centimeter and 7 centimeters. And you can see on this logarithmic scale of mean tumor molecules per ml, that is detected tumor-associated DNA molecules per ml of blood, there's a really strong correlation here. And we've used this in several patients now to detect early disease. And I think this is going to end up being very useful. So, on to the final major topic here, systemic therapy, the shift from chemotherapy to immunotherapy. Why would one explore immunotherapy in Merkel cell carcinoma? Well, it seems super obvious now, but it was very hard to convince drug companies about 10 years ago to have any interest in this cancer. It's a rare cancer. They're not going to make significant money. There'd never been a positive clinical trial for it before. And chemotherapy, as they argued, works in 60% of cases. So why would we try immunotherapy? So the arguments for immunotherapy potentially being effective is that this cancer fundamentally is very strongly immune associated. There's a 10-fold increase in risk in immune suppressed patients. As I've told you, there are non-self antigens present in both virus positive and virus negative Merkel tumors, suggesting that immunotherapy might have an ability to grab on and recognize those tumors. There's profound evidence that if there were CD8 T cells that had infiltrated into a tumor, that this was incredibly protective. Among 300 patients where CD8 T cell infiltration was assessed, not a single one died if they had good T cell infiltration. Now, only a minority, about 20–25% of patients had that CD8 T cell infiltration, but that was incredibly protective. And then Merkel cell polyomavirus specific T cells were discovered in tumors and the blood. And when we looked at what their functional status was, it clearly indicated that those cancer-specific T cells were exhausted. So this then links to the Nobel Prize in 2018, and Merkel cell carcinoma, it amusingly won an inverse Nobel Prize. Okay, what I mean jokingly about that. The Nobel Committee cited the clinical trials in Merkel cell carcinoma as reasons that Jim Allison and Tasuku Honjo, for their respective discoveries of the roles of CTLA-4 and the PD-1, PD-L1 pathway were right. And that this is an incredibly important pathway. And that because Merkel had the highest response rate of any solid tumor, that this was clear evidence that this pathway was incredibly important, not just theoretically, but clinically. So here are some of the data. This is the first study, the first drug approved, avelumab. When we compare it to historical chemotherapy data, I don't think you see a lot of graphs that look like this. These are not randomized, but here's two studies in 2017, independent cohorts, and you can see not a single person is alive. This is overall survival. This is simple. Is the patient alive or not? Not one was alive if they got more chemotherapy after they had already progressed on chemotherapy, as compared to if they got avelumab, anti-PD-L1, after they had progressed on chemotherapy. You can see that 30% are alive at 6 years, which is really a long time out and a really striking difference. Then here is first line, so that was second line or third line avelumab, and the survival is better. Here it's 46% at 3 years overall survival in first line, as compared to about 32% for second line or higher. So it really does make sense to treat with immune therapy early rather than after lots of chemotherapy, which is immunosuppressive. And then here are the data in pembrolizumab, anti-PD-1, in the first line. And this was the argument we made to the drug companies early on, and hoping that it was right. But every patient that I'm going to show you on this graph responded to their drug, whether that was pembrolizumab or chemotherapy. And this is plotting how long that response lasted. So here is the response here is the durability of responses for anti-PD-1, and then here is the durability of responses for chemotherapy. And admittedly, this is not randomized, but this is more than 10-fold difference in durability and extremely gratifying to see. Overall survival, if that's a little complicated, here's just, is the patient alive as a function of whether they got anti-PD-1 or chemotherapy? And again, a more than 6-fold difference, more than 6-fold more likely to be alive if you get anti-PD-1 than chemotherapy. So there won't be any randomized trials of chemotherapy against immunotherapy in the future because it's not ethical, it's not feasible, et cetera. But this rapidly changed management in the United States in particular, but actually around the world as well. 2 drugs were rapidly approved, avelumab and pembrolizumab, and there were quick changes in the NCCN guidelines. So wonderful, great progress, but more is needed. This is really not enough for half of patients. In fact, it's fewer than half of patients that have long-term benefit, we know now, out many years from immunotherapy alone. So the red portion of the pie here never had benefit, primary refractory disease, and the yellow portion had transient benefit and then lost it. So what do we do with refractory Merkel cell carcinoma? Where are we going? We want to convert this cold tumor with no T cells in green into a hot tumor with nice T cells shrinking the tumor, and this is what avelumab will do in the ideal and not so rare circumstance of a response. But what we know is that switching from anti-PD-L1 to PD-1 or vice versa or something like that is not effective. It's really like a switch from sort of Coke to Pepsi, and it's not very different. So that alone is not enough. If you're going to add something, what should that be? And ipilimumab is kind of the knee-jerk reaction. adding in the CTLA-4 pathway, in other words, and there is maybe up to a 20% response with significant toxicity of adding ipilimumab. So that's kind of the go-to now. Radiation, if there's only 1 or 2 or 3 escaping tumors, absolutely, hypofractionated radiation, again, sometimes just 1 dose of 8 gray is enough to get that 1 metastasis gone. And then sometimes, not nearly as often as we want, there's a little bit of a synergy between the radiation and the immune therapy for other unirradiated tumors. Intralesional therapy, TVEC is of course approved for melanoma, not for Merkel, but there are a lot of case reports showing efficacy in Merkel, and you can sometimes get that approved. There's a number of other trials for intralesional injection. And then there's a lot of agents in multiple categories being explored for the management of refractory Merkel. And I'm optimistic that some of these will work better than our baseline, which is ipilimumab with toxicity and only maybe a 20% response. I think we're going to be headed in better directions before long. We are carrying out, I'll just mention because it's interesting, a transgenic T-cell receptor therapy. This exact platform will definitely not be the future, but it's getting easier and cheaper to engineer the immune system. And this is what we can do right now. We can take T cells out of a patient. Right now it has to be HLA-A02 patients that are virus positive, and we can overnight re-engineer them, re-educate them to highly efficiently kill Merkel cell carcinoma tumor cells by putting in a very high efficiency T-cell receptor. And of 5 patients, we're seeing a similar efficacy as ipilimumab. We've had clear clinical benefit in 1 of those. This is on its way, towards next generation types of things. And hopefully we'll eventually have more high efficiency and less toxic approaches to manage these things. So now coming back to the high level of what's the role of the dermatologist in Merkel cell carcinoma management, I think of myself and many of my colleagues who run Merkel-focused groups as an orchestra conductor, because we have these wonderful musicians of the surgical oncologist, the radiation oncologist, medical oncologist, and other components of a team. But we need somebody who is going to have an unbiased, longitudinal mindset and approach to the management of the patient. They will verify that the current guidelines are being followed and can help with the long-term follow-up. These patients are all at risk for other skin cancers and will need ongoing dermatologic care. Dermatologists know more about Merkel cell carcinoma than any other one field. So we are well set up to make a big difference in the lives of our patients. So here are a few resources for patients and their doctors. There are a number of sites that focus on Merkel cell carcinoma indicated by the green stars here, and there's a full list at merkelcell.org. And there are many centers actually around the world as well that we curate and make sure that these places are responsive and interested in the cancer and promise us they're going to provide multidisciplinary care in a timely way for this aggressive, tricky cancer. And then we list them on this website and try to get patients to go to see them at those sites. So this is our website again, merkelcell.org. You can just Google it. It is usually in the top 2 or 3 hits for Merkel cell carcinoma. We get about 100,000 unique visitors per year, and that's very gratifying because we're providing free and patient-friendly explanations for this cancer, which all too often we see is mismanaged painfully and grossly. I'm sorry to say it honestly, but that is my honest opinion. If one of these groups sees what happens to some of these patients, you just shake your head and you're sad. So we want to get the information out there, and it's a tricky, rapidly moving area. So I'm not being, I think, unfair to anybody. It is hard to stay on top of this field. So if you need help, or our team is here, my email versus our Merkel cell carcinoma clinical team email, we're happy to put you in touch with resources and or references and help with tricky cases and such. So here's acknowledgements of the wonderful team that has helped us. I especially thank Tomoko Akaike, a dermatologist from Japan, doing a clinical research fellowship, for her assistance in updating these slides and such. And we have a wonderful team and many funding sources to thank as well. And I thank you all for your attention today. Bye.
Wonderful.
Hey, Bill, greetings.
Hey, how are you? Thanks
Good.
for joining us. Welcome.
Yes, thank you.
Well, thanks so much for the really just tremendous talk. I learned so much, and it just really just phenomenal how much you've done in this disease, and very inspirational to me personally. So thank you. I you know I was wondering a little bit more about the antibody responses, and I guess I'm going to ask a couple of specific questions, but kind of getting at the idea of what functional role, if any, the antibodies might have. And so I guess the questions that came to my mind were patients that receive PD-1 therapy or even, radiation. Is there data about what happens to antibody titers in that setting?
So receiving PD-1 and radiation, yes, and they're both analogous. It's interesting. Uh, Basically, no matter how you get rid of the cancer, cut it out by surgery, radiate it, or give anti-PD-1, surprisingly, the antibodies just go down. I would have thought that as you release a lot of antigen or something like that, you might get a big goosing of the system. Or PD-1 is expressed on B lymphocytes.
Mm.
And so there could be complicated biology with antibodies. But what we've seen is, for the most part, it's just a very simple relationship and it just goes down. It seems to be tracking sort of current antigen burden. Perhaps that's because antibodies last in our blood for several weeks. So if there's a little blip here or there, it gets kind of evened out over time. So what I can say is, for a first recurrence or maybe a second recurrence or something like that, the antibody test is useful. It becomes less useful as a patient has had multiple recurrences, because then it's kind of like you're primed. I don't actually know why the tumor stinks as a way to generate antibodies in an ongoing way, but that's the truth. And as soon as you chop it out, no matter how long you had it there, the immune system just forgets. There's no antibodies anymore. They fall down real fast. But as you get the cancer coming back repeatedly, and especially if you give intratumoral immune stimulation, then we see persistent antibody production for years, and the test becomes less useful after multiple recurrences.
Interesting, thanks. And so I guess then I think that you partially answered my follow-up question to that. Is there any thought then that, administering antibodies against polyomavirus antigens could be therapeutic?
So, super interesting question. We don't know the answer to that. At the high level, the target of the antibodies is an intracellular protein. So it cannot directly bind, opsonize, kill the tumor cell. What it could do, though, is localize immune reactions into the area of the tumor, and that may be helpful. But we have, as I like to refer to it, we're ignorant, and we have a picture of a burning building with a fireman outside and a few people standing outside the building, and you don't really know who's doing exactly what. We know there's more firemen and more people that come around and watch the building as it starts to burn, but we don't exactly know who's doing what. So there's reasons to believe the antibodies could be positive. There are ways that the antibodies can grab onto the target protein, the oncoprotein, and then get taken in by antigen presenting cells and then help a productive immune response. So that's a fascinating approach or concept. It's also possible that the B cells themselves that have the antibody on their surface collect tumor antigen that way and then present that. So it's clear that B cells being present in a tumor is a good thing for outcome. So it's plausible that there could be benefit there, but it's not a super direct one of antibodies just killing the tumor.
Yeah, interesting, thanks. And I guess that kind of naturally leads into another question I had. You mentioned some fairly striking data about the presence of CD8 T cells in tumors and how that correlates with prognosis. And I'm curious your thoughts on the role of pathologists in reporting, TILs, for example, on pathology reports, and that if that's useful and if that's something that's done.
Yeah, it's done reasonably often. I don't find it super useful because it's very hard for a pathologist without a special stain to anti-CD8, in other words, to say, are these little blue round cells, are they tumor cells or are they lymphocytes? It's very hard to differentiate that. And So without a proper stain, you can't really count the immune cells in many of these tumors very accurately. And then all we know is that if you have a bunch of them, it's protective, but you still have to treat the tumor anyway. So it doesn't change management enormously, and we're not routinely doing that.
Okay.
I did see an interesting question in the Q&A section, though, Bills. Noreen asks, are there any theories about why women have a lower risk of recurrence? So that is one of my favorite questions, and at least I have a theory. And that's just that women have an immune system that turns on more easily. Unfortunately, they get a lot more autoimmune disease than men, but they are protected from a lot of things. And I think that's a plausible explanation. I don't know, Jillian, you're popping on. Maybe you're saying, oh, no, I totally disagree. Or
No,
what are your thoughts?
I wanted to ask a follow-up question. Well, first of all, thank you very much for your Derm Talk seminar. It was phenomenal. My question is actually if you know of any relationship between photosensitive autoimmune diseases and Merkel cell polyomavirus. Like, I'm very curious if that's a potential trigger of autoimmunity in addition to cancer.
Well, let me answer the high level question first. And the autoimmune patients tend to do a little bit better, I think, than people without any autoimmune disease. But I'm not sure I understand your photosensitive autoimmunity. Are you asking, does that play a role in getting the cancer?
No, I'm curious if the virus, so like, there are some viruses that can cause an infectious disease, but then can also trigger a cancer, right? So I'm very curious if there's like hyperactivation of the immune system in some people that would be rare, just like the cancer formation would be rare. That could potentially be a triggering event for a photosensitive autoimmune disease.
A triggering event. Oh, you mean could a virus lead to not this virus, not necessarily a cancer-causing virus, but could a virus lead to an autoimmune? I think
Polyomavirus. Yeah, I was curious if polyomavirus had any association.
I'm not aware that the polyomavirus. So some of the other polyomaviruses, as you know, trichodysplasia spinulosa, right? The little spiny things that they make these amazing spines that come out of follicles when they're at high concentration, and that's clearly a polyomavirus. But for the most part, the polyomaviruses in human skin just do amazingly nothing. It's bizarre how there can be so darn many of them and we aren't bothered. So, but could they be changing immunity? Yes, I think they could be. And could that someday be harnessed? Interesting question.
And I have one more follow-up question. Sorry, Phil.
No, please.
So going back to the cancer side, when you talked about hot versus cold tumors and, administering like, sting agonists and things intratumorally to try to boost the response, I was curious if you're able to stratify patients like at first presentation based off of like immune gene expression to predict whether or not they would respond. So like just as a side, we're doing some work with Tufts Veterinary School for immuno-oncology trials, like the T cell side of things. That's why they brought me in. And we're finding that, certain gene expression patterns are actually counterintuitively associated with poor prognosis. And I'm just curious if you've been able to look at like, immunophenotyping Merkel cell carcinoma patients at the outset to know how they're going to respond.
So at the high level, definitely the immune signature in the tumor is very predictive of how a patient will do in general, just to surgery, radiation, and recurrence and survival and that kind of thing. It's been frustrating and hard to find clear signals about what is going to mean a patient will and will not respond to immunotherapy. We increasingly think and believe that class 1 MHC expression may play some role, especially in T cell targeted therapy. It seems to play a significant role. Interestingly, in anti-PD-1, it wasn't a huge signal. The biggest signal that's still needing to be validated is probably visible in a multiplexed immunohistochemical setting, where you're looking at how many PD-1 positive cells are there, and what is their proximity to the tumor and such. That appears to be the most robust thing. There's work from several groups, but including Janice Taubes at Johns Hopkins, that seems to be predictive across multiple cancers, including Merkel. It needs to be validated more, and it's very complex to assess. So I don't think we have, and given that we got, 50, 60% chance of response, we're a long ways away from having a magic test that says, oh, you shouldn't get a PD-1 inhibitor because we know you're not going to respond. So we're probably in the empiric land here, in my opinion, for some time. And we just then need to say, well, in the ones that actually didn't respond, we need to have tools to help them next time.
Thanks. I just want to point out that Isaac Brunel, who's in the audience, commented that human polyomavirus V6 and 7 can cause a dermatitic eruption, usually in immunocompromised patients. And thank you for that input. And I think sometimes that may have a specific histologic findings that go along with it. So thank you for mentioning that. I wanted to just go back briefly to the idea of UV, polyomavirus, and kind of how those things relate. And I'm thinking back to the data that you showed about the mutation burden in the polyomavirus positive Merkel cells. And not only is it low, it's really, really low and surprisingly low for something that occurs in skin. And I'm curious if the non-UV associated ones tend to, occur on body sites that really never see UV.
Yeah, I think that's true. It's not as stunningly true as I would have thought. We can still get them in either type. The UV ones you never see in sun protected areas, but the virus ones can be all over the place. And yes, I do think that's relevant, and there are more. Most of the BAMs we call them big ass Merkels. Sorry, when they get big, they're 7-10 centimeters on the buttock because everybody assumes they're a cyst. Those are almost always virus positive.
Interesting. Well, thanks. We're close to the top of the hour, and so I think we'll wrap up. Dr. Nghiem, thank you so much for spending some time with us today, and we really appreciate all your insight into this disease.
Thank you guys very much for organizing this very collaborative and broadly available platform. Thank you.
Thanks so much. All right, everyone, this is our last talk for this year. We'll be back next year. Check out our schedule online. All right, Happy New Year, everyone.